Oh, hey everybody. So we'll start in about 5 minutes. Sorry, I know we're like 2 minutes behind, but we will get started maybe at 7:07. We're just gonna let some people give people some time to join in. So if you want to grab a snack or some water or something, this would be the time. We'll see you in 5 minutes. Okay, we'll go ahead and get started. Hey everybody. Hi. As always, thank you so much. We really appreciate all your support. You guys are awesome. Thanks for joining us. I know it's a super cold evening and hope everybody's safe out there, but yeah, just wanted to thank everybody for being here. We get so much amazing support from you guys, comments, and we love the chat and all that stuff. So just want to let you guys know that you're awesome and we definitely appreciate it. It makes everything worth it. But yeah, just real quick, guys, we will be taking down all the questions that you have to redirect them to Marisa at the end for the Q&A, maybe some periodically throughout. So feel free to ask anything you want. Don't be shy. We like to see all the side interactions and stuff. We want to kind of bridge that gap between virtual and in person. So, you know, we want to see the interaction. So yeah, you guys be active. The quiz at the end, just real quick.
Yeah, the quiz will be 5 questions, multiple choice. It'll be given out at the end. You'll have 1 hour to complete it, and as long as you answer at least 4 out of 5 correctly, you'll get a certificate.
Yeah, so I think that's everything, guys. Thank you so much again. Marisa, if you're ready on that side, it is all you.
Yes. Okay. Hey, everyone. This is so exciting and fun. Thank you for having me. I'm pumped to be here. So let me share my screen here.
Yeah, I'll let you know how it looks.
And let me know how it works. Yeah.
Perfect.
Great. Okay.
And just by the way, we have almost 310 people here within the first 4 minutes. So we anticipate that to go up. Everybody really likes you, we can tell.
Oh my gosh, I'm just blushing. This is exciting. Okay. No, I really am so grateful to be here. I'm excited to share a couple of cases with you guys, but also just about my experience getting into PA school and then becoming a PA, particularly in primary care, which is something I'm so passionate about. So my name is Marisa. I am a new grad PA and I just started working in primary care about 3 months ago. So I am still learning so much every day and it is humbling as heck. All right, so I'm originally from Minnesota. I went to undergrad at the University of Notre Dame in Indiana, and I studied sociology there, which I loved. I feel like it helps me every single day talking to my patients and getting to know them. And that's kind of where I dove into my passion for kind of working with underserved populations and working with populations on the margin, et cetera. I did take a gap year between undergrad and PA school where I lived in Washington, D.C. and I worked in an underserved women's health clinic as a medical assistant. And then I went to PA school at Northwestern University back in the Midwest in Chicago. To note, I applied to about 13 schools. I got interviews at 5. I actually went to interview at 3 and I was accepted to all 3 of them. And I was very, very close to doing a PA MPH, but I decided against it. Ask me about that later if you have questions. And now I work in Dallas. So I've kind of been all over the place, as you can tell, which I love and is very much my personality. My main interests in medicine is primary care. For specifically underserved populations or populations on the margin, I believe really in taking care of the whole person, and that inherently actually means taking care of whole communities. I actually am a part of a clinic that often asks their providers to live in the communities that we serve, because it's so important for us to be in and around our patients and the community and just the entire culture of it. And I love that value of theirs. I ultimately went into medicine because I love stories. I love stories because I personally have kind of an interesting story myself. That's something for another time, but in learning how to love my own story, I've really learned how to appreciate other people's stories, and that is literally what I get to do every day. All day is basically just listen to patients, their stories, how they're feeling, etc., and it's so fun. Choosing the PA profession for me was not easy at all. It was extremely difficult, actually. So if you are on the fence, you're not sure if you want to go into this area or be a doctor or be a nurse practitioner or whatever, you are not alone. It took me 2 or 3 years actually to really decide on the PA profession, but once I did, it was an extremely intentional decision because I put so much thought into it. And then in my free time, I love playing pickup basketball. I blog, I watch stand-up comedy, play piano, and drink all the margaritas in Dallas because Texas has great margaritas. Oh no, okay. Perfect. So I work in outpatient internal medicine, so I only work with adults. However, I will be joining our pediatric clinic soon. I serve in a community clinic, so a community-based clinic, and we serve entirely 100% uninsured patients, which is a really interesting aspect of my job. I've studied in various capacities and locations all around the world with different underserved groups and populations. And so I'm really most at home with that community. And so it was really important for me to come into a community clinic specifically with uninsured patients. Some other specialties I did consider, however, is inpatient internal medicine or hospital medicine at a county hospital, women's health, because I did so much work before PA school in women's health, and then urgent care because I love that mixture of medicine and procedures. Generally, I give a lot of unsolicited advice, but my main piece of advice for you guys, particularly in your pre-PA life right now, is to reflect on your experiences, journal about it, write about it, jot down your emotions, all of your experiences. That sort of incredible self-reflection will truly do wonders for you down the line, whether you're deciding what career to go into, what specialty to go into, where to live, what school to go into, but really reflecting and deeply thinking about the things that you're doing and the experiences that you're having and where you're moving to and what you do in the summers and what you're researching and why and how that matters to you. It will truly be so helpful, and it will lead you to the right place at the right time, I promise you. And finally, I got into PA school with a 3.2 science GPA. I got the lowest, not a lot of people know this, oh my gosh, I can't believe I'm saying this now, but I got the lowest class grade in my entire class in PA school on a practice PANCE exam. And it predicted that I would not pass the PANCE. Now I'm practicing, I did. I mess up weekly, almost daily at my job and in life, and I am fine, and you will be too. And I think messing up every now and then is very healthy. And so I promise you're doing fine. Whatever space you find yourself in right now, you will be fine. Okay. Disclosures, I have none, but everything I say, all of these opinions are my own and no way represent my employer. All right, so on to the first case. We have a 52-year-old Spanish-speaking male here for a follow-up. Ooh, so vague, right? He has not been seen in person for about a year because of this COVID pandemic, right? He's been seen on telemedicine a little bit, but he hasn't come in for labs or anything like that. He has no symptoms today. He feels totally fine, but by the way, he needs his meds refilled. All right. So I'm like, well, what are we working with here? I look at his past medical history. I do some chart digging, and he has a cardiac history. So he has history of coronary artery disease, status post PCI. So he's gotten 2 stents placed, one in 2006 and one in 2016. He's had 1 episode of recent chest pain in the last 6 months. I'm going to try to continue to do these abbreviations. And he has a history of heart failure with reduced ejection fraction. His last echo in 2018 shows an ejection fraction of 33%, which is in fact reduced. He has a history of hypertension, but he has never seen, he's never seen cardiology in all of this, which just makes me laugh because this is all the time, right? He also has a history of chronic kidney disease. His last creatinine, which is a measure of your kidney function, was 3.49, which is high and not good. And his glomerular filtration rate, or the amount that his kidney is filtering, is 19, which is like 19% of what your kidney should be doing, which is not good, okay? The protein in his urine, albuminuria, was 200, again, a lot. And he was being followed by nephrology, but he lost touch about a year ago. Okay, so he hasn't seen a cardiologist, hasn't seen us, hasn't seen nephrology. I'm like, oh boy, but he feels fine. He just needs his meds refilled. All right, so this is one of my favorite little charts ever. I use it all of the time in the outpatient setting because I see a lot of chronic kidney disease. This is from the National Kidney Foundation. It's basically risk stratifying our patients based on their GFR, the glomerular filtration rate, and how much protein they're spilling into their urine because their kidneys are not doing their job well and protein is just going into the urine. He had 19 and 200, so he falls in, anyone can imagine the red zone is not great, right? So he falls in this red zone, high risk, should be seeing nephrology, but he just, missed follow-up. So I'm like, all right, kidney function's not great. The review of systems, I'm mostly worried about his heart and kidneys because that's what his past medical history tells me to be worried about, right? So other than that 1 episode of chest pain, he denies any radiating chest pain, shortness of breath, lower extremity edema, fatigue, nausea, vomiting, headache, or syncope, passing out. His episode of chest pain lasted about 5 minutes. He was sitting at rest while it happened. It felt kind of achy and it just went away on its own. kidney related. He denies any change in his urine output. Foamy urine. Foamy urine basically means you're spilling protein into it and it looks foamy. So patients will be like, my urine's really foamy. That's what it means. Weight loss, weight gain, nausea, vomiting, or lower extremity edema. His physical exam, pretty normal, nothing to write home about. His vital signs were stable, normocephalic. His pupils were equal, round, and reactive to light and accommodation. Conjunctiva normal, no thyromegaly present on his neck. His heart was a regular rate and rhythm with no normal heart sounds. Oh, no heart sounds. Normal heart sounds. Intact distal pulses. No murmur was heard. Breathing effort was normal. Breath sounds without wheezing, rales, or rhonchi. Abdomen is soft. No tenderness to palpation. He did have mild lower extremity edema bilaterally. And he's ANO times 3. So this is a picture of pitting edema, which is way more than +1, okay? So this is like pitting edema, you press into their legs, it leaves a deep mark, okay? I got this from the very trustworthy Google. +1 is just kind of like mild. There's like 1, 2, and 3, and then pitting. So his was kind of mild, not too big of a deal. Okay. So what are his problems? I just want you to think in your head, like, what are the problems that we're finding today? Again, no symptoms, little edema. He just needs his meds refilled, nothing else. So just think through the problems, okay? And I will show you them now. So the chronic kidney disease, he was in that red zone, like, that makes me nervous, right? He has coronary artery disease. He's had 2 stents placed. He's never seen cardiology. Like, that means he's had like scary, like coronary stuff. I'm a little worried about that. He has that hypertension, and he has heart failure with reduced ejection fraction. A lot of cardiac stuff. So for his chronic kidney disease, we just want to get all these labs for him, okay? His coronary artery disease, the chest pain, I don't know what to make of that really. It doesn't seem too scary, 1 time in 6 months, monitor it. But we do want to make sure he's on guideline-directed medical therapy, which for coronary artery disease, it's an ACE inhibitor, which is a type of medicine, lisinopril, a beta blocker like carvedilol, aspirin, atorvastatin, a cholesterol medicine, and nitroglycerin as needed for chest pain. So that's what I want to make sure he's on. For his high blood pressure, we're going to get labs today again, but it's likely, and looking through his chart, it was the cause of his chronic kidney disease. So chronic kidney disease down here, you'll see that it's usually due to diabetes and high blood pressure. That's like the most common causes. So his was termed malignant, which you don't see that a lot, but I see it every now and then in chart notes. It just means like it's so bad, it is causing your kidneys to fail and is a poor prognosis, okay? And then the heart failure, his last echo we said was in 2018. He hasn't seen cardiology. I'm just wondering what's going on. So I'm going to refer him to cardiology and order a repeat echo. We also want to make sure he's on guideline-directed therapy for heart failure, which you'll see looks very similar, but a little bit different from coronary artery disease. So we still got that ACE inhibitor, which is a type of medicine. We still have the beta blocker, which is a type of medicine. But for heart failure, we want to add spironolactone and Lasix, which is a water pill, as needed for edema or symptoms of heart failure. He had that little edema, right? But not a ton, like he's not short of breath or anything like that. Okay, so that's what I'm thinking in my head for this follow-up patient with no symptoms needing some med refills, okay? So we get his labs. His vitamin D is low. His parathyroid hormone is high. His creatinine, that measure of kidney function, has now increased to 4.59, which is not good, wrong direction. His filtration rate went from 19 to 13, bringing him down even a level lower to under 15 kidney failure, okay? His CO2 is low at 24, which his body's compensating for metabolic acidosis. His potassium is normal, and his hemoglobin is low at 11. Then he has all these really high cholesterol stuff, okay? As a new grad who's seeing a sick kidney patient, this was like one of my first patients, I just saw this star go from like red to just worse red, and under 15, like seeing a 13, I was just like, oh, I'm nervous. So I usually just call my supervising physician or text her or message her on our charting system. And I'm like, hey, like, just making sure I'm okay and I'm not, being crazy. And then she'll be like, you're fine. Or like, oh, you should change that. And that's kind of how we talk. Okay. So this patient, high risk. All right. So this is a lot of labs, and kidney stuff is really confusing. And you have to think about a lot of different parts of the patient when you have a chronic kidney disease patient. Now, when they're really sick, like this guy, he's seeing nephrology. Like he's being followed by them. His labs are being followed by them. They decide when he needs to start dialysis, if he can afford it or something. But this guy hasn't been seen in a long time. All of his labs are worse. I mean, he's like at the end of his kidney function, okay? So I'm just nervous. Like, can we wait for him to see nephrology, or does something have to happen more urgently? So some things we worry about with chronic kidney disease that I think about when I have a patient who's here for a follow-up, just needs refills on his meds with chronic kidney disease, we look for volume overload. So if they're volume overloaded, that pitting edema, they need to be on an as-needed water pill or as-needed Lasix, okay? We worry about anemia because your kidneys make EPO, which tells your body to have blood cells, essentially. So if your kidneys are not working, your body's not making enough, so you get anemic. Our goal hemoglobin for them is over 10. We always want to typically replete their iron, but they often need EPO injections to tell the body to make stuff, because we're not. We transfuse them always if their hemoglobin's under 7. We worry about mineral and bone disorders because our kidneys are not working, so our body is not getting rid of phosphate. We retain phosphate. When we have high phosphate, we have low calcium, low vitamin D. Parathyroid hormone tells our body, hold on to calcium. So when we have low calcium, our parathyroid hormone just shoots up because it's like, I need calcium, give me calcium. So you just see really high parathyroid hormone, okay? We need to replete their vitamin D constantly, and they might need phosphate binders to get rid of the phosphate, right? Because we have too much, okay? We worry about hypertension. It's usually what these patients already have, and it's often the cause of their chronic kidney disease. So it needs to be controlled, and it needs to be controlled with an ACE or an ARB, which is research, proven medications to help with kidney disease, okay? When kidney function gets too bad, we take them off of it, or when they get hyperkalemic, we take them off of it. But other than that, they should be on an ACE or an ARB. We worry about hyperkalemia. The kidneys just can't excrete potassium. So they need to be on a low potassium diet. Hyperkalemia is one of the scarier things we worry about, and I'll get to it in the next slide, but they also might need to be on a cation exchanger, which exchanges that positive potassium for other positive things like sodium or calcium. And again, like, I don't really put them on that. Like, that should be nephrology, but that's just what I'm thinking about, and that's what I'm seeing all my patients on, okay? And then we worry about metabolic acidosis. We're not excreting acids, so they build up. We give sodium bicarb. We give bicarb to counteract acid, okay? There are a few reasons why you do emergent dialysis, which I was like, does this guy need something more? And he didn't, because he was not doing any of these things, okay? AEIOU, it's a great way to remember it. Acid-base disorders, that acidemia, super acidemic, like needing dialysis. That's something you need to worry about and look at in labs. Electrolyte disturbance. Does he have really high K? Like suddenly his K is like 7 or something. You would probably send him to the ED, or you would really need to figure that out, and that is a reason for emergent dialysis. These patients, again, like, can get really high Ks, so you always look at their potassium. Patients in general with intoxication or ingestion, so that's like not my patient, that's just someone who ingested tons of something scary and they come unresponsive to the emergency department or something. and they would need dialysis. Volume overload, so overloaded so much that you're getting really scary heart things or really scary lung things. And then uremia. So they're encephalopathic. They're like confused. So my supervising physician was like, did he look uremic? And I was like, no, he's fine. He was answering questions and giving me eye contact and wasn't confused, stumbling, syncopated, So uremia. These are all reasons to emergently dialyze, okay? So before we move on to the next case, I know that was kind of quick, but I see chronic kidney disease all of the time because all of my patients have diabetes and high blood pressure. So we're just monitoring their kidney function. And that's, we don't, I think we don't appreciate the kidneys enough, but they're just so important. And we have nephrology on board constantly because, these patients can tank pretty quickly. So does anyone have questions or comments about that case?
Yeah, there were a few. And just to encourage more guys, if you have questions on this topic right now, this would be a great time to ask. We do have quite a few just like on other topics, but I'll try and focus just on the kidneys right now. And thank you for including that because I feel like that's just such a pertinent topic no matter what you go into. Like anytime you put them on any sort of like medication, I feel like there's a lot of kidney involved. So people order like GFR labs all the time. That's just one of those things that is like really good information to see. Like I see that all the time. And I hate to admit it, but I never knew it was like a percentage. So that makes a lot of sense. It's way easier to keep up for me. So that's great information.
Yeah, definitely.
So somebody's asking, could you explain the physiology behind LASIK? So like kind of how does a water pill reduce edema?
Yeah, so that's a good question. So basically, like, let me try to do my best here. Basically, if your kidneys aren't functioning, like you're spilling protein out of you, okay? And there's not enough, oh, the wording is going to get me, but there's not enough like pressure. So water is seeping out and you get like this edema, okay? And it's like all over the place. You'll see patients' legs like swollen so much, okay? And that can be from like heart failure too. That can be from a lot of things, but there's essentially like not anything pulling the water in, like the protein, so it's leaving. So LASIK, basically, there's different types, but they work on parts of the kidney. So I wish like I had a diagram of the kidney with me, but there's like loop diuretics, which work on the loop part of the kidney. And it's essentially just exchanging different ions. So water is basically coming into the kidney and getting excreted. So patients on like a loop diuretic, it would work on that part. Other ones work on like the proximal tubule. So there's like hydrochlorothiazide, there's different ones, but they basically work on those ions essentially to adjust them so they pull in water into the tubule. That's my very basic understanding. And so these patients are just peeing a ton, okay?
Got it. Okay, yeah, that makes sense. So basically what you're saying is that they're able to like urinate out all of their salts. So like they're getting rid of a lot of like sodium and that kind of stuff.
Yeah. They're like urinating what their legs would be carrying if.
Got it.
Yeah.
Okay, perfect. Thank you for that. And then somebody else, Jess is asking, since the patient was Spanish speaking, how do you deal with that? Do you speak Spanish or is there a translator? And how often do you deal with that kind of thing?
Yeah, so I unfortunately don't speak Spanish, which is very, it's something that I'd love to change, but we have interpreters. So my medical assistant, all of our medical assistants are bilingual. And so I just have an interpreter in there with me. And that's more patients than I thought, but it's a good 50 to 75% of my patients are Spanish speaking.
Oh, that's incredible. Does it rub off on you a little bit? Are you starting to learn Spanish?
It does. Like I can understand it a little bit, and I can like fumble through it if they talk slow enough, but I can understand it pretty well. Yeah.
That's interesting how that works because some people can speak like, not professional Spanish, but I feel like you're the opposite. You pick up on all the medical terminology.
Yeah, I cannot speak it like to save my life. So, and I've taken plenty of Spanish, y'all, and I just cannot. So we'll get there eventually.
Okay, so there were a few people asking, so would this patient be a candidate for dialysis? And is that like a call that you would make, or would you recommend them to nephrology and let them do that?
Yeah, I have never like sent someone to dialysis. It's definitely the nephrologist's decision. And it's a long decision in a way, like unless you're emergently being dialyzed. Like I just had a patient today who was emergently dialyzed a month ago. And now she's on dialysis. But it's kind of a lengthy discussion because it's a very, it's a very hard, thing for patients to come to terms with that they're on dialysis. There's a lot of negative connotation, of course, with dialysis. So it's definitely like a lengthy discussion that they have with their nephrologists. Yeah, I'm just kind of at that point tagging along for the ride and supporting them however they need to be supported, and then taking care of their chronic issues.
Right. Yeah. Well said. I can't imagine dialysis just seems like such a difficult thing to go through.
Right. Yeah.
Do you see a lot of differences, like as far as like cultural like myths that you have to dispel? Like you see like certain people kind of believing one thing, because the reason I'm asking this is because I worked at kind of like a similar place, and majority of the population that came through was Hispanic, and there was kind of the stigma that if you're diabetic and you have to get put on insulin, that would eventually lead to you like dying because it's an injection or something like that. So
Yeah, that I see that one a lot, like the insulin thing. Dialysis, like I've run into people who it's more of a personal, like my dad was on dialysis and died and I just can't do it or something. So I don't know if I've fully seen like a cultural, but I've definitely seen like personal struggles with coming to terms. Culturally speaking, diabetes, the insulin is like really challenging for some like larger groups of people, the Hispanic population being one of them. So I see that a lot for sure. Yeah.
awesome. Yeah, so I think that's pretty much all of the questions for this topic. A lot of them were just dealing with dialysis, and your answer kind of encompassed a lot of them. So.
Good. Okay. Ask me more pathophys. Just kidding. Okay. Share your screen again. No, that was a great question. So we'll do the last case here. Okay. So you're looking at your schedule. You are seeing a 57-year-old African-American female with follow-up from hospital admission. Okay. She has a past medical history of high blood pressure. Her ED visit was like 3 to 4 weeks ago. She was having about 3 weeks of blurry vision with halos, which are kind of like circles in her periphery, despite new eyeglasses. She was like, I just got new eyeglasses and I'm still having this blurry vision. She was also urinating more frequently and she was very thirsty. So polyuria and polydipsia. She had 15 pounds of unintentional weight loss. And her mom had diabetes mellitus, and she knew she was feeling sick, and she just thought she'd take her blood sugar, see what the machine said, and it read, quote unquote, high, and she knew that had to have meant bad. So she found herself going to the emergency room. Her hospital course found a blood glucose of over 700, which is extremely high for those that don't know. Over 200 is diagnostic of diabetes. So she is in florid diabetes. Her A1C is 12.2. Normal is under 6.5. So bad, not great. She was started on a drip of insulin and was transitioned to sub-Q basal bolus insulin with an assumed amount of insulin needed daily at 70 units, which is a lot of insulin, okay? She was discharged on metformin 500 milligrams twice a day and 70/30 insulin 25 units twice a day. So she ended up needing, I guess, only 50. And then they said, follow up with your PCP. So here we are. This is her follow-up. She is ready to talk to you. I'm seeing her 3 weeks out now. She is very overwhelmed with this diabetes diagnosis. she still just cannot see, and she's embarrassed and ashamed because her dad has to dial up that insulin pen for her to stick herself with. And she's just terrified she'll never be able to see again. She's embarrassed that her own parents have to help her with her insulin. She's also an early childhood education teacher, and she'd like to start working again, but like she totally can't with these vision problems. She doesn't feel down or depressed, and she denies suicidal ideation or homicidal ideation, which, because she was so like overwhelmed and a little anxious, I asked her more about her mood. I typically ask about mood because you'll be surprised with how depressed people are actually feeling. And then I always ask about suicidal ideation and homicidal ideation. I do that just to make sure I document that I've asked it, but I also care and want to make sure that they're not experiencing that. But documenting it is just very important medically. Okay, so she's been checking her blood sugar at home, and it really fluctuates. Remember, she started in 700, really bad, right? But now it can be like 160 to 170 or even 50 to 60. 50 to 60 is pretty low. Those are hypoglycemic episodes. She even had to like call the nurse a couple times, and the nurse line had to kind of tell her to eat some hard candy or something to get her blood sugar back up. She's currently taking metformin 500 milligrams twice a day. That's 70-30 insulin, 25 units twice a day, amlodipine 5, and hydrochlorothiazide 25. This is a pretty standard like thing that I see. When our patients specifically come out of the hospital, they're almost always on like metformin 500 twice a day, even though the max is 1,000 twice a day. And then they're always on 70-30 insulin, which is 70 long acting, 30 like normal acting, or regular. And they're on that because it's cheap and you can get it over the counter, and it's the least expensive insulin. So our patients without insurance always are on 70-30 insulin, and that's fine. It's just BID dosing. It's twice a day dosing, and kind of the standard, like if you look at diabetes treatment, typically when patients start insulin, you start them on a basal amount of insulin like Lantus, like a long acting insulin. You don't start them on twice a day insulin. But it really doesn't matter. And this is the cheapest for our patients, so it's a great option. Amlodipine and hydrochlorothiazide are two blood pressure medicines. Hydrochlorothiazide is one of those diuretics. It works on one of those parts of the kidney, and I totally can't remember which one. So, okay, review of symptoms. She denied everything: chest pain, headache, shortness of breath, nausea, vomiting, weight gain or loss, polydipsia, polyuria. She has visual acuity changes still, like she can't see that pen. And she does have mild diarrhea, and she thinks it might be from the metformin, but she's not sure, and it's very mild. So, all right. Her physical exam, pretty normal. She does have an elevated blood pressure, 178/83. We typically try to keep our patients under 140/90. And there's all this talk about, is it 140/90 or 130/80? It's just different guidelines. We typically do 140/90. Nephrologists usually do 130/80. All of her other vital signs are stable. She appears well-developed, well-nourished, normocephalic, perla, conjunctiva, and extraocular eye movements are normal. She does have poor visual acuity. We check her vision on one of those, big e-board things, and it's 20/60 in both eyes. Her heart has a regular rate and rhythm, normal heart sounds, intact distal pulses, like here. Cap refill is normal. You can't see me, I'm like doing the things. No murmur is heard. Effort of breathing is normal. Breath sounds are normal. Abdomen is soft without tenderness to palpation. Bowel sounds are normal. Skin, mood, everything's normal. Oh, she is tearful. That should be put in red. She's tearful because she's just overwhelmed. She's just overwhelmed, okay? So that's her physical exam. Nothing too crazy, but that vision, makes me a little worried. Okay. So, what's on her problem list? Y'all can start thinking. I think I have 4. So her problem list: this new diagnosis of diabetes, her vision problems, her stress and overwhelm, and her high blood pressure that she had before. So for her diabetes, she's now out of the hospital. She's in like normal life. Sure, I had, hospital labs from 3 weeks ago, but that was when she was like in the hospital and sick and stuff. So I want like a fresh new set of labs on her. So I get a complete blood count, a comprehensive metabolic panel, a thyroid stimulating hormone, lipids, and a urine albumin creatinine ratio, which is protein in your urine. I'm worried about, remember, diabetes causes kidney disease, so I want to make sure she's not spilling protein already. She has vision problems, so we actually have like this fun like eye picture exam type thing that we do that can look very like peripherally at diabetic eye disease or diabetic retinopathy, because diabetes can affect your vision pretty badly. So I'll get that today. We'll just see what that shows us. She's very overwhelmed. So we discussed coping mechanisms. Like I see, like, do you have social support, etc. And we have a social worker in our clinic that sees our patients like on the spot, which is amazing. So I offer that option for her as well. And then like I always tell patients, hey, like there's always medicine for anxiety and depression. I'm not saying that you need to be on it or we should even start it, but I'm just letting you know, like if you have this for a long time, we always have medicine for that. But I always give like the therapist or social worker talk first before medicine if we can. And then she has that high blood pressure. So it's elevated today in the 170s over 80s, which is too high. That systolic is too high. Okay, so that's kind of what I'm thinking. And, we get all these labs, and the labs are going to be important, but we have to do something with her today. So her new diagnosis of diabetes, she's on that metformin, 500 twice a day, and we have room for that. So I'm going to increase it to 850 milligrams, twice a day. She's on the 70-30, it's twice a day dosing. I kind of just want to switch her to that long-acting insulin, Lantus. It's just once a day in the evening. She's really overwhelmed, like maybe just once a day insulin will help her a little bit. So we switch that 70-30 to Lantus. I also want to consider, like in the future, maybe starting an SGLT2 or a GLP-1. Those are two different types of classes of diabetes medicines, and they're kind of newer and they're really fancy and great. And I love them. And she has really high A1C. So I'm like considering that, but we don't want to overwhelm her today. So we're not going to start it today. I do want to avoid the sulfonylurea class in this patient. The sulfonylurea class can cause hypoglycemic episodes. She's already told me she's had a couple of those. Remember, she had to call that nurse line and ask for the hard candy or whatever. So like she's already kind of getting some low blood glucose levels. And she's on insulin, which insulin can cause low blood glucose levels. And sulfonylureas can also, so we just kind of want to avoid that one. I typically avoid insulin and sulfonylurea together because they both can cause lows, but you will see them together plenty. I just don't love that class of medicine, especially for this patient, okay? And then that metformin, it can certainly cause diarrhea and like abdominal pain and all this like GI stuff as side effects. And so like I told her, listen, if this increase in metformin causes that, I know you're already having some diarrhea. If it makes it worse, if you can't handle it, just call me and let me know. That's kind of the relational like thing that you need to build with your patients. And it just takes time and like kind of a good rapport with your patient, which she was really like sweet and great. So she kind of was like, listen, I'll tell you if I'm like having a lot of diarrhea. For her vision problems, the in-office eye exam was normal, I think. But I was just kind of worried about it. It was pretty severe. And clearly this was what was bothering her the most out of anything was her vision. So I'm going to refer her to optho for like a formal eye exam, formal visit, just to make sure everything's okay. She was stressed, so she's going to meet with our social worker today. And she has high blood pressure. So she was on amlodipine and hydrochlorothiazide, but today her blood pressure is A, high, and B, now she has this new diagnosis of diabetes, which you, because you're a great PA, know that diabetes causes chronic kidney disease. So we want to protect her kidneys. So pretty much every diabetic should be on an ACE or an ARB. So we're going to add lisinopril, which is an ACE, that class of hypertension medicines. We're going to add lisinopril 20 to her regimen. So now like check mark, her kidneys are protected. we're doing good. Her labs return, pretty much everything was normal. Her A1C went from 12.2 to 12. Everything else is normal. I rarely get normal labs for my patients. Anyways, so her labs are normal. This patient is a brand new case of diabetes that's completely out of control. And she has bad vision changes and she's nervous. So, and I'm new, I'm nervous, right? Like, so we're gonna follow up in 1 month. Normally you follow diabetics every 3 months because you check the A1C every 3 months, but I wanna follow her up in 1 month and I'll check the A1C then. It'll have been, 7 weeks since the A1C was checked back in the hospital. It's not a perfect science. It's fine checking it at 7 weeks. You know, if this is someone that's brand new, way out of control on all this insulin now, like I want to see what her A1C is. So she comes back in a month. Her A1C is down to 9 from 12.2. Her fasting blood glucose is 80 to 110, and her postprandial blood glucose is 140s. Her vision is fully returned. She's back to work in a month, working with those little kids, and she's very pleased with the outcome. Okay, go back. So that's that. That is also an extremely common thing that I see. And we can open it up to questions now as well. But diabetes is like, oh boy, just everyone has it. And if you want to go into primary care, knowing your diabetics, knowing your diabetes medicines, I mean, it's just, you will be ahead of the game, I promise. So this was a good, just a good patient to like think about her blood pressure and, you know, protecting kidneys, why her vision problems are bad. You know, for diabetics, it affects your large vessels and your small vessels. And we see, you know, the vessels in your eyes be affected, so they get a lot of vision problems. We see the vessels to your kidneys get affected. We get chronic kidney disease. We see the vessels down to your feet be affected, so they get that neuropathy in their feet, kind of numbness. We worry about those wounds like on their feet, so we want to check their feet at least once a year in clinic, but they should be checking their feet all the time for like open wounds because they can get easily infected. And then we worry about the big vessels, the heart, like coronary artery disease. We worry about all that stuff. So yeah, ready for questions whenever you guys are.
Awesome. That was another really great case study because like you said, I feel like that's such like a common issue that a lot of people run into.
Mm-hmm.
But yeah, a lot of good questions here. A lot of support on how you took into like the patient's kind of like psych, you know, state into account. You know, that's such a pressing thing. So Julia was asking, in cases of psychological distress, do you provide psychiatric support, or are you restricted to chronic non-psychiatric illnesses? So like, would you just treat her diabetes in this case, or would you kind of help her with that too?
Yeah, so we treat like anxiety and depression all of the time. I typically, like for this patient in particular, it was very much like an acute, like, oh my gosh, I have diabetes and I can't see, I'm stressed, I'm overwhelmed. So usually I just have her talk that out with like our social worker. But patients with more like long-standing anxiety and things like that, we connect them to a psychiatric like care physician who they go over more like mood disorders and schizophrenia and bipolar and stuff like that. So I don't really deal with actually treating, like prescribing the medicine for bipolar disorder. So we have someone do that. But yeah, easily able to connect them. This patient doesn't need to be connected. Like she could be handled with us perfectly fine. Now for therapy, we usually only have so many visits to our social worker therapy sessions that they can do. If they need like a ton of therapy, we refer them. Yeah.
That's really cool. I hope they normalize that and kind of have a social worker at every clinic because it sounds like such an important thing.
Oh my gosh. I have the social worker help me every single day.
Yeah.
I lately it was like the addiction week this week. Like
Oh, sure.
everyone
Yeah.
is addicted to something, and it was really sad. And anyway, so My social worker saw a ton of patients this week. But yeah, she's phenomenal. I mean, you just don't have, quite frankly, like I'm someone I love that communication. I love talking, I love talking through like how are you feeling and why. But you don't have time. You like I just don't have time to be that person for her today. And so you need to like punt it to someone else. You need support. And our clinic is really good at it's the model is like this team holistic care. So we have social work, we have like diabetes education. My gosh, if you have like a new diabetic, it takes so long to teach everything that they need to know. So they need to be seeing someone else for that. So yeah, leaning on like your team members has been super helpful for me.
That's incredible. It sounds like you have a great workplace.
Yeah. Oh my
we did have some questions about that, kind of jumping off, because you mentioned that there's a lot that goes into counseling somebody with first time like diabetic issues. So there were quite a few people asking, do you do that kind of stuff? Like, do you go over like their diet and exercise, those kind of holistic measures to improve their outcome?
Yes. Yeah. I do. So we talk about diet and exercise at every visit. I'm in this, like, to be quite honest with you, I'm just still learning how to do that well and like really actually get a lot out of that conversation. I was joking to someone that the amount of times I say like continue lifestyle modifications, encouraged healthy diet and exercise regimen is just every patient.
Right.
But to like really dig into that takes so much time and you just don't have it. But talking through, like I typically am like, all right, we're just going to talk about like your lunch. Let's only talk about your lunch and what you're eating and like exactly maybe like one thing to switch out. So I try to make it manageable, but I'm trying to figure out like personally as a provider and just in primary care, how to say, you need a healthy diet and exercise regimen. And like, instead of saying that sentence 200 times, like something being done about it.
Yeah.
It's really hard. It's probably a, national chronic issue. But we see it all the time, right, in primary care. So, but we do have teams that like only work on weight loss with patients and stuff.
Definitely. I mean, that seems like it's a skill set in its own, just being able to kind of get through to patients. And so on that note, there was a question on compliance. So how do you deal with patients in regards to compliance? Like if you know that they're not doing their drug routine or whatever it may be the way that they're supposed to, and how often do you see that kind of thing?
Yeah, we see it often. But usually it's because a patient just straight up doesn't know like why they're taking something. And so they're just kind of not taking it. Or they forget. The patients who like aren't picking up their medicine and just like aren't taking medicines for months and months and months, and we've given them a contract to sign and we've been like, we are a clinic that is serving you and like we get funding to serve you for free and like you really gotta come halfway on that with us. If patients just aren't doing it, we have to have kind of a frank conversation, which sounds bad, but you sometimes have to be like, hey, we need this from you, and if you're not able to do that for us, like we just might not be the clinic for you, and you're not getting what you need out of the clinic, we're not getting what we need, and you might just need to find a new clinic, honestly. And I haven't really had that conversation a ton. And this is after like 1 or 2 years of trying to work with a patient, right? But compliance can be tough, not only with just taking medicine, but like showing up to your appointments. We have, like I said, diabetic teams where these patients see them like every 2 or 4 weeks, like constantly.
Wow.
So showing up to those, like bringing your blood sugar logs. This patient of mine was great because she was worried and a new diagnosis. So she like had everything to a T. I frequently have patients who don't have any of that with them, and I'm just working off of an A1C, which is fine, but not great. in medicine, you really need like those blood sugars. So it's kind of a mixture of a lot of things. And I'm learning quickly as someone who just like really does want to partner with you for as long as I possibly can. I'm learning quickly, like you gotta meet me halfway. Like we can only do so much. And if you're not willing to do it, I mean, like, what are you going to take 100 units of insulin and just not get better? Like you got to work on your diet too, you know? So it's a hard conversation. I'm still learning every day, like how to be stricter with patients. Yeah.
Yeah, I mean, absolutely. Thank you for the transparency on that, because I feel like those are those kind of topics where, you know, you're not going to learn it in undergrad, you're not going to learn it in PA school until you actually go out and see it for yourself. And it sounds like your clinic is, you know, in a really good place as far as, you know, education and all of that stuff goes. And to hear that still that you have compliance issues, I mean, you're not going to be able to do it 100% of the time, no matter where you are, right? So
yeah, and like we're all humans. I mean, I'm a terrible patient myself, you know. Like I get it. Like I'm not taking my iron pills either, but you should be, you know. And like it's just you kind of got to give them some grace too. And yeah, it's all you learn as you go, for sure.
That's awesome. That's very well said. I feel like that's a massive takeaway from this, is just like you can really tell how much you in particular care about the patient. You know, a lot of people are just kind of like, this is like our biggest thing in healthcare, that we hate that people are treating people like just like numbers. You know, they just kind of come in like, oh, you have diabetes. Okay, I know I need to give you this medication, do this, whatever. I'm going to tell you this. See you later. You know, 5 minutes and you're done.
Yeah.
But like you said, making that connection and really educating the patient means everything. So thank you for that.
And I was telling someone the other day, I am such a bad provider right now because I really am learning. I'm a fine provider, but I'm like, this is the worst provider I will ever be, because I am just like clinically learning so much. When they're telling me about their headaches, like I am actively thinking of my differential and like what we need to do. And so sometimes I don't lean into the conversation as much or ask about their weekend, because like I'm just trying to figure out clinically what's wrong with you, because I'm new. And so I feel like I even still am like, I've told myself, you know, for the first couple of years of practice, like I have just got to give myself grace. Like if you are not connecting with your patients all of the time or asking all of these questions, like it's fine, because you just need a little bit more time to actually think of the clinical medicine side.
Yeah.
But I know, like, you know, you see these doctors who have been doing it forever, PAs who have been doing it forever, and they're just like, you know,
Oh man,
rolling in the room like, hey, what's up? I mean, it's 90% fun, relational, because the 10% of medicine, like they know exactly what to do with their insulin. They know exactly what new medicine to add on. Like, so I think it'll get, you know, again, better, but yeah, let yourself like be a beginner for sure.
Incredibly well said. And it's so funny because we were just talking about that. Nobody would ever know that you're like new to this. You seem like you're so like on top of it, experience everything, like you're presenting everything. But yeah, I mean, that's another great point that you make, is like kind of having that maturity to realize that making mistakes and being new is a normal thing, you know, like it's a lot. I know everybody expects to graduate and know everything, but we're finding out more and more through these sessions that that's just not the case. Everybody learns on the job. PA is such a diverse specialty that there's no way they can teach you 100% of everything, right? So yeah,
Right.
that's a great point.
And that's also what makes you a great provider, is you know when you don't know something, you're able to admit that, and you're able to accept your mistakes, and that's what's going to make you even greater, is learning from your mistakes. So
yeah, you learn. I mean, you really do learn so much, and I'm grateful. I could go on and on about, you know, like picking the right job.
Sure.
I'm grateful for where I practice, because I can ask all of my coworkers at any moment a question. I have a hard time with derm stuff. Like if I've just never seen that on someone's body, I just don't know what it is, you know? You can like try steroid cream on pretty much anything, but I'm like, what the heck is this? And I frequently have my coworkers just come in and take a look. And I was like, you know, are the patients going to think I'm crazy? But our patients are great. And they're just like, oh, thanks. Like, you know, another provider, great. And my coworker will be like, oh, that's exactly XYZ, or I don't know, but try this treatment. So I'll like literally have them come in and help me out. I mean, it's really freeing to finally be like, hey, I don't need to know the answer. And that is different than being a student. So I walked into rotations as a student very overwhelmed, like very stressed, because you need to know the answer, kind of. You want to look good, you want to learn. It's just not as freeing to like get things wrong and ask for help. But as a provider, I mean, that is what it is. You have to ask for help. There's no other way around it. So I didn't feel that way as a student at all. Like I wasn't just like, let's make mistakes. I was like, let's like do good on this rotation, Marisa, because you want to do good. But yeah, that's one thing I'm learning as a provider. It's actually more freeing than as a student in a lot of ways.
Yeah.
Strange.
I mean, that's a really good sentiment, because I guess at the end of the day, as long as you keep the patient's best interests in mind, right? Like what are you more concerned about? You maybe seeming like you don't know something, right? Or the patient getting the best information. So definitely well said. But we have a couple more questions on this topic, and then we'll let you get back to it. Sorry, I didn't mean to start this side thing, but there's been a lot of really good information. So, but let's see.
So the next question is from Millie. She's saying, I've heard that people's blood pressure can be elevated at the doctors because of nervousness. So is this taken into assessments or taken into consideration when doing assessments?
Yes, it definitely is. That's such a great point. So yes, it very much is high in clinic all the time. And, you know, we're seeing these patients a couple times a year. And so it's hard to adjust medicines based on like one reading. For this patient, I knew she had high blood pressure, and I kind of trended some of this stuff in the chart prior, and it was kind of high, and I knew she needed to be on a third agent. Now I could have added lisinopril and like taken away amlodipine or hydrochlorothiazide, but we'll see. I have her, so what I have patients do is check their blood pressure every day. I am thinking about adjusting that actually. I was listening to the Curbsiders podcast, which is a really great podcast if anyone needs a good one. But they were talking about blood pressure, like what do we do about patients and their blood pressure? And exactly what Millie said, like we only get this one reading, it's not super helpful. So they actually have patients take their blood pressure 3 times in the morning and average the numbers, and then 3 times in the evening, average the numbers, and do it every day for 7 days. Send me the information, and that's a much better replication of what your blood pressure actually is. I right now just have patients take it once a day. I just say it doesn't really matter what time. Try to take it a couple hours after you've taken your blood pressure medicines, right? Like, so we know if they're working. And then like send me 2 weeks of your readings, and we'll go from there. So I'm frequently just like calling patients and asking for their blood pressure readings. Yeah.
That's so refreshing to hear. Like, it just seems like you guys are really on top of your patients rather than just kind of like setting them free and like, okay, whatever, I give them their stuff, I got their money, see you later. You know, so that's it's really good to hear that. But yeah, sorry.
Environment. It might be like we do really work with a certain population, and our providers have felt very called to this area of medicine. So it's a fun group to work with. But I do think it's like a specific type of provider for sure. Yeah.
But I mean, I don't know if you plan on staying with this group forever. I mean, it certainly sounds like a great group, but just having that experience now, I feel like will carry into anything that you decide to do in the future, right? Like just having that background is so important, you know.
Yeah.
But kind of on the topic of hypertension medication, a few people were asking, how exactly do the hypertension medications protect the kidneys? Like, do they work in tandem to,
Yeah. So the mechanism of action is working right on the RAS system, which is like the renin, angiotensin, aldosterone system of the kidneys. And basically that system like tells the kidneys that we have enough water or blood or like whatever, and do all the things that you need to do, kidney, and either like keep more, like we don't have enough, like the kidneys aren't getting enough blood, like keep more, or like we have too much, don't keep more. So it kind of is this system, and you could like write it out or Google it or something, and it has all these things or something, and it has like angiotensin converting enzyme, which is ACE, and that helps the system go. And the system is like yelling at the kidneys all the time. And so an ACE inhibitor is something that like stops part of this system and is ultimately renal protective. An ARB is like another type of hypertension medicine. And it's like an ACE, but it's a little different. It works in a little bit different way on that system. So you don't ever want to use them together, but if someone has like a side effect of an ACE, like lisinopril, you can start them instead on an ARB, like losartan. Both work on the system that is constantly talking to the kidneys, and so it's renal protective. That's the best.
Oh yeah, that's an amazing answer. When I think of hypertension, my brain always goes to like cardiac issues, like heart attack, stroke, that kind of stuff, just due to prolonged that. But I never kind of make the association with like renal failure. So it's definitely good information to know. We'll do one more question.
You get like the cardiorenal syndrome. You get where like all of it's all sorts of bad. That's a bad one. Yeah.
But so one more question on this case study. Heather M was asking, what's A1C and how does it differ from checking blood glucose?
Oh yes, okay. I'm so sorry, I didn't say that. A1C is a measure of the average blood sugar over 3 months. So diabetes has a lot of ways to diagnose it, but one of them is an A1C over 6.5. Me and you and other people were like in the 5s, maybe like under 5, 4s, low 5s, whatever. Once you get like 5.7 to 6.4, you're pre-diabetic. And then over 6.5 is diabetes. And so every 3 months, we see our diabetics in the office, and we check that A1C. It would be a disaster if we were only like counting on patients to check their sugars and write them down, because they sometimes don't do that. And so an A1C, like you just can't hide. You can't hide like you've had a bad diet for 3 months, or you can't hide you're not taking your insulin. So the A1C is just super important, and we trend the A1C. Now the blood sugar is important because first of all, if it's like super high, like 500, you maybe need to go to the hospital depending on your symptoms. And it's really low, you could pass out. That's like really bad as well. So we want them to like stay in this hot spot range. And I like when they give me all their blood sugars, because especially if they're on insulin, if they're like AM sugar is really high, that means the insulin that they're taking in the evening is like not doing the job for the morning sugars. So I would have to adjust that nighttime insulin. But if they're like after lunch sugars are super high, then their morning insulin isn't really doing the trick. So I would adjust that one. So you kind of like know maybe what insulin to adjust.
I see. Okay. So kind of what I got from that is that the blood glucose seems to be more of like for acute issues, whereas A1C is better for tracking their diabetes overall over the long run and kind of predicting the future of what you plan on doing.
Yep. Yeah. A1C is important for like outpatient. Blood sugar, just the finger prick one time acute reading is more important, like probably for inpatient.
Awesome. Okay, perfect. I think that does a pretty good job of covering everything for this case study. If you want to go back to your presentation, we'll come back during the Q&A.
Okay, I just have like more unsolicited advice for you guys. All righty. Here we go. So clinical advice, particularly for primary care, which I adore. But if you're wanting to go into some sort of general primary care, family medicine, whatever, I'd highly recommend taking the electives of orthopedics, dermatology, women's health, and nephrology. I just see this all of the time. And I'll kind of go into it here, but like ortho, just the amount of aches and pains and shoulder pain and back pain is just incredible. So an ortho rotation would be super, super helpful. Derm, I just am really, I'm weak in that area because you don't get a ton of it on your rotations. You don't learn about it a ton, but you see it all the time. Patients with weird little rashes or itching this, or this looks strange, or discoloration here. I mean, you just see it all of the time. And so I wish I took an elective in derm. Women's health, you typically take an elective, or you typically have like a core rotation in women's health. But you see a lot of women's health and outpatient. You do a ton of pap smears. You talk about mammograms, like why they should get it, why maybe they should wait, why they should get it early. You see a ton of yeast infections because of raging diabetes that's uncontrolled, and now these patients are getting yeast infections all the time. You just see a lot of women's health. And then of course, birth control and like navigating that. We unfortunately do not do IUDs or Nexplanons in our clinic. So I wish we did. And then nephrology. If I haven't convinced you enough to do nephrology, the kidneys are confusing as crap, and it's so pathophysi. And I like constantly am like drawing it out and looking at the pathways and all of that. The kidneys are tough, and you just see it all of the time. So a good nephrology rotation would be super helpful as well. Things I see all the time: diabetes, high blood pressure, chronic kidney disease, coronary artery disease, thyroid issues, hyperlipidemia, anemias, like low blood counts, COVID, a lot of COVID, anxiety, depression, and addiction, and then aches and pains galore. You will be ahead of the game in primary care if you know in detail all of the hypertension and diabetes classes and medications, a good shoulder and knee physical exam, how to read EKGs, and next steps for all blood count abnormalities like liver lab abnormalities, worsening kidney function, thyroid abnormalities, high triglycerides, or a basic room workup. Even as a new grad, I still know when something feels off, and I hate when people say this, especially as someone who, as you can tell, is just very like, tell me how it is, tell me actually what it means. But truly, if you know that something feels off, listen to that gut. I've had a couple of patients, we've had a lot of patients actually, who like, they just seem off, and we send them to the hospital and they frequently get admitted. I was trying to convince a COVID patient for a week and a half that he really needed to go to the hospital because he couldn't breathe, and he just like wouldn't go. He also had like, he was on warfarin, a blood thinner, so he had to get his INR checked a lot, but he wasn't able to because he had COVID. He also had like black stool, which makes you worried that they're bleeding. He ended up going to the hospital, and he had an INR of 9, which is just absolutely insane. And it's amazing that he wasn't just like bleeding out of every pore of his body. And he was admitted for a week and a half. So listen to your gut and call your patients constantly if you're worried about them. And then ask 1,000,001 questions. I've told you now, I do it all the time, every single day, constantly, to all my coworkers. I just ask a ton of questions, and you learn so much. And you just got to humble yourself and ask the question all of the time. Okay. Life advice. I hope that you remember that you can simultaneously be a very capable, smart, detailed provider, and also at the same time be this like confidant and friend and comedian and pal with your patients. It's like you can talk to them about, I say here, like you can talk to them about like their new shoes, or like my one patient does like this dancing type class of his. So he was telling me about that. This woman was telling me about her new Fitbit watch, and she loves it. And it's my favorite story of any patient I've ever had so far was this Fitbit watch patient. You can talk to your patients about all of this. And like really lean into it. And for me, like why I went into primary care, I love the medicine. The medicine's fascinating. I just gave you 2 really common things that I see, but like we got some sick, crazy stuff going on with our patients. I love the medicine about it. But I love the little tiny details of stories so much. And it's like a privilege to be in kinship with my patients in that way. And you can do both. Like you can be brilliant and great at the clinical stuff and like lean into that small little mundane stuff. And it's a joy. So I love my patients and I love primary care. I'm such an advocate for it. And I've kind of based my clinical interests off of this bodies floating down the river story. And it's, to me, a perfect example of having your heart in primary care. So, yeah. Do I have anything else? That's all. Q&A.
Awesome. Thank you so much. We definitely appreciate all the unsolicited advice. That's why we're here. But yeah, I just wanted to thank you for sharing that kind of stuff, because we were kind of talking about this earlier, and I know that we're here to provide shadowing, but we really want to sort of better information and the type of people that we're sharing our platform with. And we just love you because we feel like you have some amazing values. We can tell that you really care about your patients, and that's what I mean, I know that we're here for the shadowing and for, like, you know, the science behind it, but all that stuff that we're going to get in PA school eventually. But
Right.
we want to kind of subtly focus on the patient care side, and kind of those little quirky things that you talked about, right? So there's always that stereotypical doctor that everybody walks in and just being like really smart but doesn't want to talk to you, you know, the specialist, the neurosurgeon, the arrogant guy. But yeah, I think you hit it right on the head when you said that, like, definitely you can be personable, you can be charismatic, like, I mean, be those things so that your patients like you, right? So yeah, I just wanted to give you a shout out. You're awesome. Thank you for doing this. But yeah, let's go ahead and get those questions. Yeah. Oh, by the way, would you be okay with us plugging your Instagram just in case these guys want to follow you or anything like that?
Yes, that would be, yeah, go for
Well,
it.
what we'll do is we'll drop it in the chat and we'll pin it. So anybody that wants to do it, they can, or follow you, they can just click on it and just follow. We highly recommend, guys. She has an awesome Instagram, a lot of good information, some cool, you know, just like quirky little tips, information, nice selfies. So yeah.
My Instagram game is like not super strong, but the story game is, you'll see me.
That's where it's at. Yeah.
Yeah.
Okay, perfect. Okay, so I will just take it to the top, from the top here. So earlier, Dan and Tina were asking about the PA MPH program that you talked about. Is it 2 separate degrees? Is it one big program that you add on to? Could you just kind of go into talk a little bit about that?
Yeah, so there are definitely some PAs on Instagram who did both, and so I'll try to find those and like post about it or something. But mine was, it would be 2 separate degrees, and it was, the MPH was going to be the first year, and then PA school was the second year and the third year. And it was a small cohort. It was like 5 of us who were going to do it. And so we would, I even think they might have, no, that makes sense. So it was like a small cohort, and you would do your public health degree first. And I think you took a couple of PA classes with, you know, that PA class, like while you were doing your MPH a little bit. And then when that was done, you like full blown started PA school. And so as you can tell, I mean, I love public health. I love social determinants of health. I studied sociology. It's just like, I love it. I love it so much. And I really believe in it. And it's how I want to practice medicine. I feel like if I want to do an MPH, I personally like wanted to do like a very like intentional MPH program, and I just thought that tacking it on to the beginning of my PA program, I would just be like too excited to get to the PA part of it and like not lean into it like my personality needed. So yeah, like one of my best friends got her MPH before PA school, so separate, but and she really does feel like it influences her practice. So it's certainly something like I'm considering. I just wanted to do it like very much, like very intentionally, right? Like at the right time. And for me, tacking it onto PA school was, I knew I would just not be like, I would just want to be in PA school. So yeah.
Cool. Yeah. Thank you. We never really have heard about that much. So it's a unique aspect.
Yeah. There's very few. So
very cool. So we have so many questions about PCE all the time. So a lot of people are asking, what did you do for PCE? Did you have a lot of hours? Just anything about your PCE you want to share?
Yeah, weak point in my application for sure. I think I had exactly however many Northwestern needed, so I think 2,000. I worked as a home health aide in a memory care unit in an assisted living home. I didn't need my CNA for that for some reason, but everyone else had it. I probably should have had it, but so I never had my CNA, but I did all of my experience in an assisted living home basically as a CNA. And then I didn't have enough hours to just apply and go right in after undergrad. Because if you think about it, you have to apply like a year in advance, which means you need to have those hours like when you apply.
Right.
So I just had to work for like my full 2,000 when I applied. And then I knew that my gap year, I wanted to do like Teach for America actually, or something more educational. But I knew I needed hours if I'm going into PA school. So then I worked as a medical assistant through if anyone's heard like of AmeriCorps or Peace Corps, it's like that, like a volunteer year. So again, I didn't actually need a medical assistant license. I was able to just be a medical assistant. And that's how I got like an additional 2 or something like that. So yeah, that's how I got it. I think I had one of the lower amounts of clinical experience going into PA school. And I remember talking about it in one of my essays and just being able to like flip that into like a huge positive. And you can do it. If you don't have a lot, you can always flip anything into a positive. So yeah, that was how I did it. I had a lot of friends who did EMT stuff. I know. I had one friend, she was a dietitian first before going in. I had one friend who did clinical research. And then I think scribing personally is the best thing ever. I wish I did it. Like I didn't know any of those CAD and CKD and all of that. I had no idea what that was going into PA school. But I think some schools don't consider scribing as patient care experience. You just gotta be a little, so that's why I didn't do it. Like I was totally considering it and I was like, I don't want the stress of it maybe not counting. But I think it's the best experience actually, for sure. Yeah.
Awesome. Yeah, I feel like we have so many questions about PCE all the time, just because it is kind of like that weird, unique thing where like there's a million things you can do. Like, you know, nothing's better than the other. It just kind of depends on how you grow out of it, like you said, you know.
Yeah.
But yeah, thanks for talking about that.
I was able to get jobs essentially as a CNA without having my CNA license, which sounds sketchy, but I was able to do it like 2 or 3 times in large organizations. So I would look into that. If you're not looking to get another license, but you want to practice. EMT is really great too. And then I think anything like in a hospital, you know, of course is helpful, but that can be harder to find.
Yeah, that's really well said, because I don't know if it's like a state type thing, but in Texas, I know that you can be a medical assistant without having like, you know, certification. Same thing with CNA, like patient care tech, all that stuff. So A lot of the time, if you look at like the application for a job posting for these type of things, it'll say like under the recommended section, whatever type of certification. But I mean, it's worth shooting your shot, right? You have nothing to lose. Just put your resume out there. So.
For sure. Absolutely.
So let's see. Jane was asking about your clinic, and she's asking about like the financial aspect. So is it more affordable since you see a lot of patients that may not have insurance, and how does that interaction work for you?
Yeah, it's a whole nother ball game. I didn't know anything about this space truly until I was a provider in it. So our patients don't pay any money really. I think they pay like a small copay for their visit. And then all of their medicines are discounted at our pharmacy. However, now there's like so many $4 meds like at Walmart or something. Right. So medicine can be like a lot cheaper now, but yeah, discounted meds. And then they can get onto this application program that gives reduced or actually free medicine for a ton of fancier medicine. So like all insulin, all inhalers, lots of the new diabetes medicines, certain other, I don't know, things. Insulin and inhalers are big ones. So they like fill out this whole program, and then we have groups that we work with, or like pharmacy companies that we work with that give them to us for free. So so there's that. And then we have volunteer specialists that see our patients. We don't have all specialists. So if we don't have them in our system volunteering, just like their time, we have to send them to our county hospital, where it's like a long wait and a long application. They're great. It's just like, it's another step out of our system.
Right.
So that can be a little challenging, but like we have full teams in our clinic that do referrals only and like all of that stuff. And then we just, partner with everyone and get free everything essentially.
That's incredible.
That's incredible.
Yeah. I mean, it's an insane program, and it's through a giant hospital system in Texas, and they have like multiple community clinics. And it's just a model that's like truly incredible, and it keeps the sickest patients healthy, and it saves the system millions upon millions of dollars for them not going into the ED or being hospitalized or whatever. So, I mean, the model is incredible, and we're trying to expand it. And it's a really unique way of doing medicine, but it works. It makes perfect sense. And we're caring for some of the most medically and socially fragile patients in our system. And like, we do a good job at it because we have a ton of resources in it. So
that's so cool. I mean, what rewarding work. Unfortunately, it's not a perfect world, right? And everybody's finances takes a big place in their medical necessity, right? So,
right.
But yeah, that's awesome. So let's see, we have a few more questions. One that just popped up that seemed to get a lot of support was from Nathan. He's basically saying that he feels like he's lacking shadowing hours. I mean, due to the pandemic, it's just such a normal thing now. It's been such a strange year. So he's just asking, what kind of advice do you have for this upcoming cycle to make yourself stand out when you lack shadowing hours?
Yeah. I just think there's so many aspects to the application where you can stand out. Shadowing is certainly not the most important by any means. It might be for certain schools for some reason, but I would not fret. I think what you're doing by being here is amazing, and this will count. I mean, this really will help. I think schools will give a little grace because it's COVID, and they know that we're just like simply not taking people to shadow right now, or we weren't for like a year. But I think like highlighting how you've turned a problem into like how you found a solution to the problem by coming here, or by engaging more like online more, and doing that, I think that's gonna be, your best bet in terms of shadowing. But I just think, shadowing is a small component of your application. I shadowed a ton of doctors because I thought I wanted to be a doctor. And I only had like under 10 hours of PA shadowing. So I do think some schools just want to make sure you've know that you actually want to go into medicine. I think you can convince them that you know of the PA profession in more ways than just you had a ton of shadowing hours. So
right.
Yeah.
Definitely. So that's kind of one of the things is that a lot of people ask us, is this going to count for my school to hit the shadowing check mark? And we do all we can to make it as respectable as possible. We provide you all the information or fact, send you the certificate. We make sure that the quiz is done within an hour so that we make sure everybody's here live. But at the end of the day, since this is just such a different thing, we don't know if every school is going to be like that. We've reached out to a few in Texas, and we know definitely we're going to accept that. But who knows how it is elsewhere. But the big takeaway is just the fact that, now we're up to 400 people just sitting here watching this. It's such an investment in your future because, we're the ones that host these sessions. We're always at all of them. But we've learned so much just from this session alone, so this information is invaluable, whether you're using it the way we don't want you to, which is just kind of being here so that you can get the certificate and then say hey, I was here, but yeah, definitely. So I feel like just the fact that people are taking the time out of their day to sit here at 7 o'clock and listen to somebody talk, that speaks volumes for yourself, and just kind of think of it that way, this is definitely an investment in your future. So
yeah, and I really am so grateful that you guys are here. I just am blabbing to you, right? And so, but I hope I hope these are helpful for you guys. And even sometimes, I'm just going to be honest, what I'm sharing is what I wanted to hear. That's actually what you need to know in your shadowing. You're going to see patients all the time. Shadowing is, I don't know. I think this kind of shadowing is, it's just almost more beneficial than in person because you get a chance to really hear some of the nuances and the details that actually matter for your practice.
Yeah.
So yeah, I sure hope this counts. If you have a school that you really want to go to, call them and ask them about it. You being here, I promise you're already ahead of 95% of people. And there are so many other parts of your application that will shine. This is just one of many components. Also, any weakness anywhere in your application, I am someone who is fully believes that your essays, the writing component of your application, is the most important part. And that's an opportunity for you to either share hey, this was weak, but this is why it's actually strong and I did a good job. So you can always write about it in some way, to discuss weaknesses or why you didn't get enough shadowing or something. So
yeah, definitely. And to kind of piggyback off of that, even if you reach out to the school and they say they don't take it, there should be somewhere in your application you could list this, maybe an extracurricular, and you can really use that description to sell it and show them how much you learned from it. So.
Totally. Imagine a school looking at you and they're oh, they only had 25 shadowing hours. And then they look at extracurriculars and it's 85 Zoom shadowing hours that don't technically count for your school, but 80, right? My God, I would be what are we doing? That it would just speak volumes. So
yeah, no doubt. And I know shadowing is kind of the topic right now, but it doesn't just have to apply to that. You can use that for a lot of things. So maybe your care hours are low, but you have insanely high volunteering. We'll kind of use that. Yeah, my patient care hours were low because I was spending so much time volunteering with this thing that I really care about. I'm so passionate about. But that's a different conversation in itself. And I know that you're really big on that. So maybe that's something that you guys can stay tuned for on her Instagram.
Yeah.
My other subtle plug, right?
I love it.
So a few more questions, if that's okay. We're doing okay on time.
Yeah.
Okay.
What else am I going to do tonight?
Okay. So Alexander's asking, on a full work day, how many patients do you typically see?
Yes. Okay. I do actually want to talk about this because I think it's important. So I work in an outpatient clinic. We have three other doctors and a nurse practitioner and me. I'm actually the first PA they have ever hired ever. So that was new, and people tell you to not do that, but it's fine. You can do it. You'll be okay. And at any time, there's like 3 providers typically in the clinic. We all have our own patient panels, and we are each the primary care provider for those patients. So I am the full PCP for my patient panel, and the other providers are not seeing them once a year or seeing them every now and then. I am the provider, okay? Now that's different from a lot of other specialties sometimes for PAs. That can also be different for primary care PAs in other states or in other clinics. I mean, I got really lucky. As a new grad, I see less patients typically a day than everyone else. We have 30-minute appointments for our patients, which means we see 16 patients a day. I am just slowly working up to that. So in like 6 to 12 months, I will eventually be seeing 16 a day. But right now I see like 10 a day. So I get breaks here and there to allow me to catch up because I'm slower, because I'm new. And so that's how many I see a day. It's always 30-minute sessions. Again, that's very unique. Usually it's less than that for primary care, which is so hard to even, talk about everything you can in 30 minutes. But, and then I right now have to have every single one of my notes co-signed by my supervising physician. Once I'm out of my new grad, new experience, like in a year, it won't be 100% anymore. Technically for our state, or I don't even know if it's the state, but our clinic, whatever I'm told to do, I have to have my supervising physician co-sign 10% of my charts all the time. Whether I've been working for 2 years or 20 years, it's 10% of charts. So usually you kind of want some insight on at least 10% of your patients because they're challenging and make you a little like, what's going on? And you want someone's second opinion. So that's really, I don't know. Some people would be like, oh, you need supervision or something as a PA, but that's what you will normally do no matter what. I can't tell you the amount of times like all of the providers go to all of the providers for insight or advice on a patient. So I think, anyways, so that was a long answer, 10 patients. But that's kind of how it works with the amount of charts that need to be co-signed. But my supervising physician doesn't ever have to see my patients or like have her eyes on them every now and then. They're my panel of patients. So I love that about my job. And that's what I wanted personally in my career. So it's worked out really well. And we were talking about this earlier. It looks so different in everywhere, in different clinics, in different states, in different specialties. I was telling them like the Emergent in Northwestern in Chicago, the PAs in my emergency medicine rotation, the PAs saw the most acute patients in the ED, and the doctors saw the less acute. And of course, the doctors in that setting are co-signing every note. In most inpatient settings, a doctor is co-signing every note. But they were seeing the most acute patients, right? And then like my friend's ED rotation in Minnesota, the PA saw the least acute patients, and the doctor saw them. So your role will look so different. And I think I used to, for the longest time, think it was like, I'm either a doctor or a PA. And it's really not like that. I do the exact same thing my doctors are doing. We are just all doing the exact same thing every day. I just need, well, right now 100%, but I will just need 10% of my charts co-signed. That's about it.
That's awesome. No, yeah, that was a great answer. That was our next question. Actually, a lot of people ask about kind of autonomy and the relationship with the supervising physician. So yeah, you're right. That's what we've seen here as well, is that everybody's just totally different. So I mean, specialty, clinic, everything goes into account. State, all of that stuff makes a huge difference.
Yeah, that's probably our most asked questions as well whenever we're having a session is how much autonomy do you have, and do you work closely with your supervising physician?
Yeah, and I always can call or text her, like the kidney patient. I don't know. I just was like, I've never seen a GFR of 13 and he's just like hanging out. What do I do? And she's like, nothing. He's gonna go see nephrology. So I can always call or text her. I also have a great relationship with like the coworkers that are always in the clinic every day, so I can ask them. My supervising physician is not in the clinic every day, so that's why I say call or text. Or I'll just like send her a message on our charting system, like, hey, I just had XYZ questions about this patient. So we work pretty closely in that regard, and I always have someone to ask a question to if I need to. So, but she's very open, and she like works with residents and stuff too. So she's great at like educating and being in that, role. So I'm very lucky for sure.
That's really cool, because I feel like that's one of the really cool things about PA is always having somebody to kind of shoulder on. But
Teamwork.
then again, maybe not necessarily, right? It just depends on who you got. Like, right.
Yes. Yep. Yeah, I've learned quickly that finding a job not only was hard, but you gotta find the right job. You just gotta. And they're hard to come by sometimes. So you gotta know what you're interested in and what you need. And I needed a lot of, I didn't need like hand holding by no means, but if I have a question, I need to ask someone my question today, and I'm able to do that. Very
Amazing.
Very cool. Well, let's see, maybe a couple more questions and then we'll wrap it up if that's okay with you.
Sounds good. Yeah.
Perfect. So Julia was asking about your opinion on the name change. This is another hot topic we see all the time. So she's asking, how do you feel about it? Do you think PA is a good name, or does it need to be changed?
Personally, I wish it was changed, because assistant really has, people know what that word means, and it does not mean they're provider in a white coat. And my patient population does not care, and the amount of times I've gotten called Dr. Olson, even on notes by other providers, I mean, like, people just don't notice or really care. But yeah, the word assistant is just tricky. And so, because our clinic has like medical assistants, so I always call patient like, hey, it's Marisa, the physician assistant at the clinic. And patients sometimes think I'm the medical assistant at the clinic. So I think a name change would be helpful. Now, we're already like getting going with this name, and people are slowly starting to know the PA profession a little bit more. So it might confuse people even more. I was told to just say PA, like, a lot of people I ran into were like, just say you're a PA. And like, who cares if they know what that means? So I just say like, I'm a PA. And if they're like, what? Then I tell them, but they don't really care. But you will run into some patients who are like, I want to see the doctor. And I've only seen that a couple times on rotations. I've never seen it here, but and those patients, like, I used to think about that scenario and I was like, that would make me so sad. Like, I never want people to think I'm some sort of way. But you go tell the doctor like, oh, this patient in room 1 like wants to see you instead of me. And the doctor's like, I don't want to see that patient either. Like, they sound mean. I don't want to do it either, So like, no one likes that. And you don't run into it a ton. And not my population, you really don't. So.
Yeah.
I feel like that's something you shouldn't take personally. And I feel like it kind of says more about them than you. So.
Sure.
Yeah, for sure.
Let's see. Okay, so we always like to end on something that's kind of food for thought for the future. So if you could just discuss where you think the PA profession is going in the coming years. So I know it's been really crazy with like, you know, a lot of change happening, pandemic, telehealth, a lot of programs opening. So like saturation is, you know, there's just so many things. So what is your outlook on the future of PA?
Yeah, gosh, you know, I should like read more probably about what's going on. But I'm really positive about it. I think you get more and more providers working with PAs that are great, and they're like, I love this, and this is great. And they're capable, and they learn quick, and so like you see just a lot of providers really liking the PA profession. And I'm hoping that that really continues. I do wish the PA profession was more, was in certain specialties more. So like you don't see as many in pediatrics, you don't see as many in women's health. So I'm hoping like that increases a little bit more too. But I'm really hopeful because coming from someone who was like crippled with indecisiveness about whether I wanted to be a doctor, I just am like so grateful I chose this path, especially doing what I'm doing. I mean, I just feel like it's like totally the best of both worlds. And you still are such a capable provider, and learning on the job is equally, if not more beneficial than spending years studying. So I'm really hopeful for it. And I think it can only go up. And I mean, clearly, like statistically it is, and like job ranking it is. So yeah, now I will say I'm not super hopeful for like people knowing what our profession is. I just think there's like a long way to go with people truly understand. Like my parents are still truly understanding what a PA is, you know? So for patients to really understand like our capabilities and like what we can do and exactly what our training is like, I mean, that's just going to take a long time. So, but I'm learning that it really just matters, like for me at least, it really matters what my coworkers think of my capability. Like they're the ones that are like championing me on this journey and like being there for me, I guess. So if the doctors I work with are like, hey, you're good, like see all those crazy patients and like let me know if you need anything, that's like really what matters, I think, is making sure the medical like professionals see the PA as a good, you know, thing. And I think they do. I think.
Awesome. Yeah, definitely. And as the profession grows and as we start seeing these things like, you know, moving up on the job list and getting these sorts of recognitions, I feel like it's opening the door for a lot of people who are going to come into it for the wrong reasons, you know, because like there's always that myth that we're so big on dispelling that, you know, work-life balance, you get a lot of money, not a lot of school, like this is very competitive and you have to have a heart for it. And I just wanted to kind of highlight the correlation between your personality and how much you enjoy your profession, because this is something that we've seen clinically through Pre-PAPals, right? We see that people that are like you, that genuinely care about what they're doing, really care about patient outcomes, are the ones that seem so happy with their life. Whereas like, you know, there are those people that go after it because, oh, well, my grades are good, I hit these check marks and now I can do this. It's not for them because it's just not what they're passionate about. Of course, this goes for any field, but we just feel so strongly about PA. You know, we really love this profession. So we want to make sure that everybody here is kind of doing it for the right reason. Everybody that does do it in the future does it for the right reasons. But like you said, if somebody is here spending the time to watch you talk, then it seems like they're way ahead of the game. But yeah, we just always feel like it's important to drive that point home. You're like the embodiment of it.
Yeah. Oh, good. That makes me happy. I told y'all it took a long time to think about it. It really, I don't know. To me, the PA profession is you really got to know what the heck you're getting into. And like, no one, and this is like hyperbolic, but no one knows what a PA is. I mean, you're choosing a profession that like no one knows about. That you gotta love it. Like you gotta know what you're doing. You have to be passionate about it. Because I will for the rest of my life be explaining what I do to people and explaining my credentials and telling them like I went to these schools and like I like can prescribe medicine. I mean, you have to explain that to someone at a party and also your patients, right? And so it just, to me, when you choose the PA path, what a gift, you know, because you had to put a lot of thought into it, because choosing to go to, I don't know, like choosing to be a doctor, like I think your parents tell you you should do that since you're like 4, right? I mean, this takes so much thought, and I'm so like good on y'all for being here and doing this, because I mean, you're way ahead of the game. I promise you. And I promise you this is a good career, really good career. I love it. Yeah, big fan over here. So I'm proud of all of you, and I really do wish you guys the best. And if you need anything, please, you know, don't hesitate to ask. I will do my best to stumble through some sort of answer for you.
Oh man, I can't think of a better way to end it. Really, thank you so much again for doing this. You're awesome. We love everything that you had to say. Like we said, our values really line up. We really appreciate you for doing this.
Yeah, no problem. Anytime. So, and you guys are doing, you know, as you know, a great job. So we're all very, very lucky to have you guys on this platform.
That means everything. We really appreciate it. And so tomorrow this video will be posted on YouTube. So you can actually go through and look at all the chat if you want to.
Yeah.
I know it scrolls like the whole time, you know, it's crazy. But just to kind of give you an idea of what everybody's saying, like there's so much love for you in the chat the whole way through. Like everybody's talking about, I try to jot some of it down. Great personality. Loved how you talk about stories. You're so inspirational, smiling the whole time. Amazing info. Thank you for talking about this. Like just so much love for you in the chat. Millions of thank yous. So yeah, everybody really loved you. So it is definitely a pleasure to have you here. I think that goes for everybody.
Yeah, seriously, you have such a great personality, and we can really tell that you're a really great provider.
Sure. Yeah.
Everything that you've been talking about, like we said, our values line up so well. So
right, very genuine information. Doesn't seem like you're just doing this. And I mean, there's no way you would just be doing this, right? There's no benefit to you to do this. I mean, we always try and stress that point, is just like, you're taking time out of your super busy day, you know, like you could be doing whatever you want, but you're just taking a minute to give back to the pre-PAs, give back to this community. It's amazing, you know. So we hope that stays with our viewers tonight. So like when you guys are PAs, you know, just try and think about that. Like you have these really cool mentors and these really cool people that we've been able to see through this platform that are willing to do this kind of stuff. You know, great personalities just share a bit about themselves. So keep that in mind, guys. We want to make sure that all of you don't just get the shadowing certificate, whatever. We want to make sure that all of you guys are amazing. Like once you go into PA, you're going to be like, you know, inspired by all this information, like take some of this stuff to heart, like, you know, the really important things. So
yeah.
But yeah, thank you so much, Marisa. We can't thank you enough.
Oh gosh, of course. Anytime. No, thank you guys. Have a wonderful night. Let me know if you need anything. Okay?
All right, we'll do. Take care.
Thank you so much. Have a good night.
Bye-bye. All right, guys, wonderful session. Thanks so much again for joining us. We love having you here. We try and keep an eye on the chat all the time, and we love all the side conversation. You guys are so helpful, and that's just such a cool thing for us to think that, like, you know, this community that we have here is so helpful. It's not like, you know, really cutthroat and competitive. Everybody's just trying to look out for themselves. It really seems like everybody cares about each other, you know. I noticed one person said that they got into PA school, so congratulations to you. But on the same note, it's so cool to see how many congratulations you got. So we really care for you guys. We love to see that kind of stuff. If you want to share like your cool stories with us, we get that every so often. Like somebody will say like, hey, I got into PA school. And that's just like, I mean, come on, what better, you know, I don't even know what the word is, but like we love to see that kind of stuff.
Yeah, not too long ago, we actually got a message from someone. She told us that she got accepted to PA school, and she was telling us about it and that she loved our platform. So it's so awesome to see. So if there's any more like that, send it our way. And if you want us to post it to our story, we'll definitely do that. It's super exciting.
100%. We want to keep you guys, empowered. We want to give you the best information. We want to make sure that when you guys come out, you're badass, so but yeah guys, so on that note, we will be having sessions all the time. We're fully booked for February. We're starting to spill into March, so we're not slowing down anytime soon. We're trying to do them weekly now just because we don't want to spread our presenters thin. We don't want to do like 2 or 3 in one week because I feel like that takes away from one, like rather than the other. But anyway, so yeah, just look out for our posts. We'll be doing them once a week. We're going to try and move the times around a little bit. I know some of you guys have work late or work early or whatever, so we're going to do them on different days of the week, and maybe have an afternoon session, morning session, weekday session, weekend session. But yeah, guys, stay posted. We'll get you those shadowing hours, good information, all sorts of different specialties. If you have any requests for a specialty or anything you want to talk about, you can always DM us. We're about to post the quiz right now.
Okay, so something about the quiz, please bear with us on this. So we just got a new add-on to where we can send the certificates automatically, so you don't have to wait on us for like that week to send the certificate. For some reason right now, this limit is still like 97. So the first 97 who pass the quiz should be emailed it automatically within a few minutes. So when this happens, it's gonna close the quiz. But I'm gonna have to reopen it. So if you see something like it's not available, please refresh it. And if you have any problems with it, just message us. We're gonna keep it open for an hour. But again, if you see that pop up, just refresh the page. I should be trying to, sorry, I lost my train of thought. Open it again manually.
All right, so here comes the quiz, guys. We will hang out in the chat. If you have any questions or anything's going on, you want to ask us anything, we'll be right here. But as always, guys, thank you so much. Y'all are awesome. Best of luck to everybody who's applying this application cycle or in the future or whatever it may be. So you guys are awesome. Keep it up. We'll see you next time, all right? Take care.
Bye, everybody. Have a good night.
All right, bye.